She also holds a professional diploma from the Braintree Rehabilitation Center in Surrey in the UK, where she is also certified as a neurofeedback trainer by the BCIA Institute. Dr. Tsatali has worked for Alzheimer HIAAD since 2009, while serving as research associate at the Medical Physics Lab of the Aristotle University. She is lecturer in the Department of Psychology at the International Faculty of the Europe campus for the City College. And in 2020, she became an academic fellow with the Psychology Department of the University of Ioannina. She has participated in several Erasmus research projects, has contributed to multiple interdisciplinary conferences as an oral or poster presenter, and is the author of many published papers. Dr. Tsatali today will be speaking to us about a very important topic these days that we're all trying to grapple with, specifically cognitive and behavioral changes potentially related to COVID-19 quarantine in people with MCI and dementia, a longitudinal study. Dr. Tsatali, welcome, and the floor is yours.
Good evening, everyone. I want to thank Professor Lyketsos and his valuable team for the kind invitation. And I would be really happy to make a fruitful discussion about this significant topic I will present you in the end of the presentation. Give me a few seconds to share my screen. Okay, so as you can see here in the agenda, at first, I will talk about some informative issues relating to what's happening about the significant topic of pandemic and the effect in older adults population. And I will say a few words about the methodology conducted in our study, because it's a significant project with also a sequel study following to the one I will present you. And afterwards, I will focus on the results and the conclusion. And of course, it would be, as I said previously, really significant to talk together and share our impression about the results of the current study. 2 years and a half after the start of the pandemic, I personally think that we know too many things relating this unexpected situation. However, we have to learn a lot about that, and especially what really happened in the case of older adults population who have multiple health problems, and especially those who live with a dementia. This is a multifaceted phenomenon, because these people face also many restrictions due to various health comorbidities, and also many challenges related to physical, mental health, and of course, quality of life indexes. So we had a general motto which says, let's stay at home, but it's not so easy, it's not so simple, because especially in people living with dementia, they are heavily dependent on various health services. They need social support, and many of them visit dementia care centers in their communities and participate in various activities. And also,
Marianna, I'm sorry to interrupt you, but your slides are not advancing for us. I don't know if you are indeed advancing them, but they are not advancing for us. Can you put on slideshow, or maybe show a different page?
Okay, let's see what can.
You should make a share screen, not sharing the PDF, the PowerPoint.
I did share screen, but
that's better. Yeah.
Can you see them changing?
Yes. Mm-hmm.
Okay. I'm sorry for that. So as I as I discussed previously, there is a general motto, let's stay at home, but it's not so easy because of the various challenges affected this population, whereas at the same time, people living with dementia have, in a large majority, coexisting neuropsychiatric disorders, which is a really significant problem, and many previous studies found significant deterioration of BPSD in this population. The extra difficult, the extra significant issue is that these people could not understand the reason for social isolation, and therefore cannot apply adaptation skills and adaptive mechanisms in order to cope with them during the pandemic. So we are talking about a multifaceted problem, a multi-level problem, consisted of reduced mobility and access to various services, decreased cognitive stimuli, as well as social contacts, and of course, as I was talking previously, possible worsening of BPSD, mainly irritability and depression, according to literature. Taking all this into account, we have many questions. We had many questions, and as about the research hypothesis of the current project, we assumed that our stakeholders in Greek Alzheimer Association of Thessaloniki, specifically those with MCI and Alzheimer's disease dementia, would have impaired cognitive performance, as well as increased depressive and stress symptomatology, and also, especially those living with dementia, would have deterioration in their behavioral disturbances, according to the previous studies results. Here you can see our expectations. We expected to find that our stakeholders would have impaired independent living indexes, behavioral disorders, impaired cognition, and of course, worsening in anxiety and depression, according to their records in the relevant psychological tests. The participants, the stakeholders of our daycare centers were recruited by St. John and St. Helen, the two daycare centers in Thessaloniki, after receiving the official diagnosis. And the common characteristic of this population is that all of them were receiving a constant support during the pandemic, but also the majority of them were participating in non-pharmacological interventions 2 years before the pandemic. I will show you the design. So we collected those participants with MCI and Alzheimer's disease dementia who had initially come to be tested in 2018 between May and July, and had completed the neuropsychological and neurological evaluation. And we wanted to know who of them also completed the first follow-up evaluation 1 year after, in 2019. So we recruited this population and called them in order to implement the second follow-up, but okay, the majority of them called our helplines to set the appointment. So it's something that is included in the policy of our daycare centers to continue after the initial assessment, to continue with the follow-up studies. So during October in 2020, we had the data process and earlier in 2021, we prepared the paper, the whole manuscript, and of course we started to do the future study that I will show you afterwards. So in order to evaluate the cognitive performance of our participants, we tested not only their general cognitive ability and of course the dependent living, but also specific cognitive domains, for example, memory, visual memory, working memory, episodic, as well as verbal memory and learning. And also we tested their visuospatial skills, executive function, and attention. So this was a big battery of tests in which participants were being tested. Here you can see the eligibility criteria in MCI and Alzheimer's disease dementia population. The official diagnosis was in line with DSM-5 criteria, and as I was talking previously, their common characteristic is that they were receiving psychological support, and also some of them were participating in cognitive training online groups. Some of them were receiving telehealth support and every kind of support that they need to have in any case, through telephone, internet, social media, whatever. And here you can see the specific tests which have been administered initially at the baseline and the two follow-up consecutive assessments. Talking about the cognitive training and the support our participants received during the pandemic. To say a few words about that, at the beginning of the pandemic, we transformed, let's say, our on-site cognitive training groups into online training groups, and also we provided computer learning sessions in our stakeholders in order to familiarize them with internet use and how they can participate in our cognitive training online version. So they also received cognitive assessment as well as cognitive rehabilitation, psychological support, and also medical appointments with the neurologist or any other kind of medical help that we could offer them. Additionally, for those who had many questions about the pandemic, we published some informative booklets in order to ensure that they would have the most recent and appropriate information according to the data existing in this time period. So let's go to the statistics. At first, we calculated the demographics and, of course, the descriptive statistics of the whole battery, the neuropsychological tests, the psychological tests, baseline, of course, 2 follow-up assessments, not 3. And afterwards, we want to know not only the descriptive statistics and across the 3 years. We didn't want to know if our participants have been deteriorating through years. We want to know the deterioration rate. If the deterioration rate between 2018 and 19, which is the D1, is better to the deterioration rate 2, which is the time period between 2019 and 2020, just after the pandemic. So according to our research hypothesis, we assume that the D2 would be increased. The deterioration rate after the pandemic would be increased, and this could be explained due to the circumstances of the pandemic. And after the repeated measures ANOVA conducted for the deterioration rates calculation, we made path analysis in order to see whether the possible declination of D2 could be attributed due to depression, anxiety, symptomatology, etc. So we wanted to know if increased levels of mood disorders and stress disorders could be the better explanation for increased deterioration rate, which is D2. So it was a complete packet of statistical analysis to see if we could insist on our research, on our initial research hypothesis. So here you can see that we had 407 participants. Both, of course, MCI were more compared to those with Alzheimer's disease dementia. You can see more about our demographics in our published paper. And here you can see the results of the deterioration rate. What is very impressive is that we didn't find increased deterioration rate in our tests, either measuring cognitive performance or psychological tests or behavioral disorders, but the deterioration rate was increased only in 3 tests. Focus test, which measures independent living, Ray auditory verbal learning test, which measures verbal learning, and verbal fluency test. So here you can see the first results from a table arised by repeated measures ANOVA. The significant main effect of condition means that deterioration rate 2 was increased compared to D1. So, okay, this is the good point according to our research hypothesis. So it seems that irrespective of participants' diagnostic group, we showed a statistical significant difference between D1 and D2. It means it seems that D2 was deteriorated compared to D1. Of course, we found significant main effect of group. Alzheimer's disease dementia had worse scores compared to those with MCI, and significant interaction is also in line with the previous main effect of condition and group. And here you can see the results from verbal learning test across the conditions have been tested. Ray auditory is a test consisting of a list of words and assesses verbal learning and memory. And here you can see that the immediate recall, the 5th trial, as well as the delayed recall were decreased in deterioration rate 2 compared to D1. However, no significant differences were found for the diagnosis. It seems that the deterioration rate is not affected through years. It's the same compared to D1, so it didn't change. And here is the 3rd test, which measures verbal fluency. Again, we see that pandemic, according to the current results, could affect their performance in verbal fluency. But this is not only the case. We wanted to know whether this deterioration in D2 could be attributed due to depressive anxiety symptomatology and behavioral disorders worse. So if the pandemic really affected negatively participants' performance in these tests, we could say that tests measuring depression, anxiety, and behavioral disorders could predict deterioration rate 2. excuse me, I wanted to show you the path models before coming to the initial table. So here you can see that the only predictor of deterioration to declination across these three tests is a diagnosis. It seems that participants in both groups have been deteriorated in these tests because of the disease progress, because of MCI progress, because of Alzheimer's disease progress. As you can see here, the path models in 2019 and 2020 are very similar. So we can say that something different happened after the pandemic, and the graph of 2020. So it's very impressive because it seems that those who had worse anxiety, symptomatology, and depression, and increased behavioral disorders as measured by MPI could not this does not necessarily mean that they had worse performance in these tests, which is really impressive. And this is a final table to explain the fact that despite that we have three tests affected by the pandemic, however, this deterioration cannot be attributed to the pandemic and the expected declination in mood and stress status. So if we could say something about cognitive training or preventing factors or whatever, could be test your verbal fluency or test your verbal ability, but this is irrespective of the effect of pandemic. It seems that they are very sensitive tests, and there are cognitive functions which are at first impaired irrespective of the pandemic, at least according to the results of the current study. We can generalize. So this fact could possibly shed light on the real effect of the quarantine of people with MCI and Alzheimer's disease dementia, and highlight those domains which are at great risk of deterioration. Because in general, our data are not supported by the other studies from literature which found significant statistical significant deterioration in cognition, mood status, behavioral disorders, and so on. However, to our knowledge, these studies were not longitudinal, and the majority of them included self-reported measures. So unfortunately, not a clear comparison can be done. But what is very significant, and we can say that this is the real role of health services, is that those who were living alone had significantly higher levels of anxiety, lower levels of well-being and activity. So the real effect of pandemic is, according to the current study, of course, is not that they stayed at home only, but there are some specific prerequisites which explain why some people were negatively affected and some others not. So it would be really significant to test those who didn't receive psychosocial support from those who received. A very significant study from our colleagues in Athens say that their participants were negatively affected in mood, communication skills, activity levels, and mobility indexes. However, they used self-reported measures, and we didn't, unfortunately, use self-reported measures. So a general conclusion could be that quarantine and lockdown measures imposed does not necessarily mean that someone with a minor or major neurocognitive disorder or a caregiver can necessarily be deteriorated, because according to our recent study, it seems that even caregivers did not have emotional burden irrespectively of the person with dementia status. Those who said that we feel really emotional burden and we have increased negative feelings, said that their person of dementia was deteriorated during the pandemics. So it has to do individually with the specific participant, the specific caregiver, if they received support and many other factors. So it's not that the quarantine was a big monster according to our findings. And very impressive is that caregivers told us that they feel quarantine in their daily life in general because they have let's say lockdown measures imposed by their situation. So some of them said that they didn't feel any difference compared to the pre-pandemic situation. So here you can see some literature, and also you can read some more information if you want, of course, if you're interested in our published paper. And as about our future perspectives, we have recruited from the initial poll of 407 participants the next studies population, which is 253 participants who were tested between May and June 2021. It was really significant to recruit participants who didn't receive telehealth support, and of course, really significant to compare self-reports, objective measures, and of course, neuropsychological data. So after so many changes in our lives, the world really changed, and it was such an unexpected situation. We didn't think we reached the point. It's more about to learn about this situation and hope that the follow-up study would shed light on whether this great benefit could be the same or can changed or whatever. So we will see it after the SPSS analysis. And a few words about whether people with MCI are satisfied with the online interventions. This smaller study has been presented in the virtual Alzheimer Europe conference last year. We provided self-reported measures via Google Forms to our MCI population who attended online cognitive training, and we were asking them about possible benefits due to their participation in tele-cognitive interventions. We wanted to know if they prefer online or on-site interventions. We wanted to know their feelings. So we managed to recruit 344 participants who were familiar, of course, with internet use. So this is a biased, we have to be honest, because those who were not familiar, unfortunately, did not answer. But to give you a whole picture about what do they prefer, the majority of them said that they really want to continue to do online groups. And if you are wondering about the reason why, the positive and the negative effects of their participation, the majority of them told that transport facility is a big positive, and if someone lives in Thessaloniki, totally understand this situation, because we have terrible transport system. So except from the transport facility, some of them said that health protection was a very a positive issue for continuing participate in online intervention. But we had also negatives, which is lack of social contact and of course technical internet difficulties. So lack of social contact is really a big issue, a negative issue, and we can't distinguish cognitive training with social support. It's part of the same gain. Social support increases cognitive training and also participants' performance. This is the study I was talking about during the presentation. Hope to have the sequel study soon. And of course, if you have any questions, I would be really happy to make a fruitful conversation and exchange options, your feedback, whatever needed.
Very nice work. Wonderful. Thank you for a very effective presentation and being on time, which is always very good. Gives us more time for discussion. So let me open it up to the floor. I have a bunch of my own, but I'm going to hold off until others get going. So Nico, I see you up.
Thanks, Costa. Marianna, great presentation. I would like some clarifications because some of the things I missed, I couldn't understand in the analysis part, just to make sure I got it correctly. So in the repeated measures ANOVA, you compare performance on some neuropsych measures or functional measures, and you compare the period before the pandemic to the period after the pandemic?
Yes.
That's the group effect? Yeah.
Yes, thank you for the question. D1 and D2 were calculated by simple mathematical subtraction. So let's take, for example, MOCA. We subtracted their scores in MOCA in 2019 from the scores in 2018. Okay, and this is the score. If the score was positive, it means that they were deteriorated. Okay, so we have the same scores for D2, 2019 and 2020, and we had two scores, D1 and D2 per each test. So we did repeated measures ANOVA with all these tests, and we separated the clusters. We did repeated measures ANOVA for the cognitive tests. We did separate measures ANOVA for the ecological test. Okay, and the only significant differences were in these three tests.
Okay, so let me understand it a little bit better. So, but if somebody has their MOCA in September of 2018 and has a repeat MOCA in April of 2019, and you subtract these two tests, part of the period is within the pandemic and part of the period is before the pandemic. So, or if somebody had it in December of 2018.
Oh, no, it was the same period, May to July 2018. The first follow-up was May to July 2019 and May to July 2020. The time period across the 3 years was the same.
Okay, so a potential explanation could be, so that's very helpful. So the reference time period that you compare includes almost half time period before the pandemic and half time period within the pandemic. So
pandemic started, sorry, Nico, pandemic started in early 2020, not in 2019.
Okay. Yeah. Oh, I see. Okay. Yeah. Okay. So the first period. Okay. The second period then, May 19, right, to May 20. Then that's a period where you have half time right outside the pandemic and then half time within the pandemic. Correct? Because it started in the beginning.
The majority of time was respective to pandemic, because pandemic and the current time imposed in March 2020. So we had only 3 months.
Right. So the point is that you may underestimate. So one of the reasons that you may not detect significant differences could be, this. So it could be that you may underestimate, maybe a steeper slope during the pandemic.
Yeah, you're totally right that the fact that what's very significant is that we didn't observe statistical significant changes even in GDS, even in SAST, which measures anxiety, even in NPI. Their deterioration rate did not change just after the pandemic. Okay, personally, I didn't expect to find increased deterioration rate in cognitive tests because, okay, it was only 3 months, okay, March, April, and May. So, okay, this is not the case, but even GDS, SAST, and NPI were not affected. To my opinion, this is the case. But okay, it's very significant to say that these people received support. We don't know what happened to others. We didn't have access. We didn't have access to those who were not familiar with internet use. And okay. if you observed in the paths presented previously, GDS did not predict any of these tests. GDS was not included, was not even included in the path models. The relationship was very, very low. It seems that NPI was more predictive in 2018 and 2020, but GDS was totally disappeared from the path models.
Marianna, what might have helped, because I'm a little bit unsure myself, what might have helped, and maybe you have it and you can show it to us, are all the data at the top line measures. So for example, what are the mean MOCAs at the first period, beginning and the end and the second, what have you, and the same with the NPIs, because I am having a little trouble understanding. I think I understand your time periods. I think, I'll read the paper later, it'll be more clear. But you never really showed us raw data. And for me, I find that raw data are really critical for an audience to understand. Yes. So, but this kind of gets me to another, I think, important point. How many tests did you administer?
Yes, of course, raw data are very significant and they are included in our publication. I excluded from the presentation in order to be consistent with the time and focus on the interesting part of deterioration rates, to my opinion, at least to my opinion. So you can see the raw data. So initially, we did lots of tests in order to see what happens, but putting them all together, of course, it was very significant to eliminate some tests because we couldn't do such a big ANOVA, repeated measures ANOVA. So we eliminated the tests. We put 8-9 tests in the initial assessment in order to be aligned with statistical significance, because if we put more tests, the statistical significance is lowered, and if we put a smaller number of tests, the statistical significance is what we expected. Yes,
can I add something?
Actually, let me, this is an important point. Sorry, Nico. The fact that you did many tests, regardless of the fact that you only check significance on a subset, does not change the fact that your p-value was diluted. The p-value is not diluted by what tests you analyzed, but it's diluted by what tests you administer. You already took a bunch of bites at the apple. So arguably, you showed us statistically different findings on 3 tests out of 9, right? So to me, it's questionable, if I could say that with respect, about whether I can interpret these data with so many repeated measures and so many comparisons. So I certainly, and I'm surprised the reviewers didn't ask you for that. I would have wanted, and maybe you had, some discussion of repeated measures the fact that you administered a lot of tests diluted your p-value, regardless of whether you chose a subset to do the comparison?
Actually, we made clusters before the analysis. So it was a different cluster for independent living tests, different cluster for psychological tests, because yes, there are various sets of different psychological and neuropsychological tests. So yes, if we put many tests together, yes, our results are questionable. So after identifying what's happening with our multiple data, we eliminate the tests for this reason, because the significance would be questionable. But I'm sure that reading the whole paper, we could have a better discussion about that. But yes, we took into account the number of tests.
A very brief follow-up on Costa's question, because it relates to, the presentation of the raw data. I don't know, maybe you already did it, and I'm bringing owls to Athens, right? Did you try any, measures, any other statistical tests different than repeated measures ANOVA, like, GE or some generalized random effects model? Because, when you look at differences, you don't take into account the baseline values. That's how, this, comes as a follow-up to Costa's, comment. And then you may get very different results when you have two different values rather than the differences. And you may even find more or less, it depends. And you may be able also to better, control for potential covariates in these models. So maybe you already explored it, but you may get slightly different results and maybe more interesting if you investigate down that route.
No, the answer is no. We did only repeated measures, and afterwards the path models for those who were, of course, statistically significant. It's very interesting. However, no, we didn't conduct such kind of analysis. However, if you could see the raw data, it seems, of course, that there are great differences. Of course, there are great differences, but we wanted to know if the deterioration rate could differ, because if it won't differ, we can say that something different happened due to pandemic. It's about disease progress, okay? So our research hypothesis was to see what's happened after the pandemic. Because yes, of course, it's very obvious looking at the table of the raw data that yes, they were deteriorated, especially those with Alzheimer disease dementia. You can see it without any statistics. It's very obvious. But the key point is that nothing different happened. Yes, something happened, but can't be attributed to impaired mood symptoms and the behavioral disorders that someone could have during the very difficult situation of the pandemic.
Yeah, I would encourage you to talk with people who are experienced in difference of difference analyses and who are methodologists, because I think this is not the approach that they would recommend you use analytically for all the reasons that Nikos mentioned, and you could get very different results. But at any rate, these are what you got. So let me see if I understand this conceptually. You have people with dementia and MCI, you are tracking them on many measures over time, and then the pandemic happens, you continue to track them, and you're saying, is there a change in slope? Right? And after the pandemic, is the slope changing? And you want to be able to say that the presence or even the absence of a change of slope is due to the pandemic, right? And because you couldn't randomly assign the pandemic, in my view, you're missing a control. Because you're really talking about a secular trend, right? That's sort of the technical term. You have a secular trend question here. So the control that I think you're missing is, what does your population do over time before the pandemic? In other words, if you take an identical population of people with MCI and dementia from years back who are not exposed on the pandemic, but you can create similar timeframes, time A and then time B, which simply would be a matter of years. That would give you a much better sense of whether the pandemic changed anything or whether it was more of the same. I don't think you can do it with a delta of delta based on what you're saying. So that might be something for you to think about is you've got large numbers of data. Does it make sense to go and pull out a very similar sample of people at baseline from your records from 5 years ago and follow them over 4 years to see if after the second year you've got an inflection point or not? Because it's that contrast that will tell you whether you really have a secular trend.
Yes, at first, different analysis, of course, would be, yes, it would be really nice to enrich the statistical issue. So, yes, I like this, this perspective. And the answer is that we didn't have a control, as you're talking about it, because we want to see what happens with our stakeholders, which is really significant because these people received our help and so on. But we have conducted similar studies in the past, before the pandemic, and we have 3 years, a recently published study, including 3 years cognitive training, and we were assessing these people during the baseline, the first, the second, and the third follow-up studies. So, and in this study, there was a control group from the waiting list because some people could not attend the on-site cognitive training groups. So, this is a clear comparison about what is happening. We calculated the progression rate to Alzheimer's, and this is interesting to see if something happens the first year, the second year. So this is really interesting. But yes, in these studies, we didn't calculate the deterioration rate. This is the first time we calculate something like that because of the special issue of the pandemic.
We have some time. I just wanted to stimulate the discussion with another question, which might imply a different analytic methodology. So you're basically presenting us with a null finding, perhaps a small effect on functioning, but we'll look at the raw data, but you didn't show them. So I'm reading it as null based on what you told us. But there is the interesting possibility that there might be a subgroup of people who progress more than others. So one of the methodologies that you might think about is called growth mixture modeling. Growth mixture modeling takes trajectories of individuals, so person A, person B, person C, and tries to ask the question as to whether these trajectories can be clustered into groups. So now you're moving away from group comparisons to trying to define clusters of groups. Think of it as factor analysis in steroids over time, right? But do you have groupings of trajectories? And so I think that might be an interesting analysis because there might be vulnerabilities. So you might be finding a small to no effect because the effect is being diluted and the subgroup that's really declining is not detectable. Whereas a growth mixture modeling approach might allow you to say, oh, well, look, I've got this very unique trajectory of people. Maybe it's 20% of the people, but what's the deal with them? Why are they going having faster deterioration?
Yes, that would be a very interesting next point because the explanation is still an open issue, so never ends. The next data from 2053 participants, I think that they could shed more light on this, but it's not only about the sequel study, it's about the statistical analysis. Very interesting, very initiative, very to the point. Thank you for the feedback.
I feel like Nikos and I are monopolizing Marianna. Do others have thoughts or comments? What clinical experience
Marianna,
that oh, go ahead.
Yeah. So overall, how many time points do you have in your analysis? Overall, how many?
Time points?
You mean you have 2 before the pandemic and 3 after? How many?
Yes. One baseline and 2 follow-ups. Baseline and first follow-up before the pandemic, and the second follow-up just after the pandemic, and the third follow-up would be after the second wave of pandemic in Greece ended approximately last May.
Okay. So maybe these inflection point models that Kostas mentioned, maybe it's something feasible. I'm not sure whether you had something that retrospectively goes even further back. Because I'm still, worried about this contamination, because, the time period where you compare has, 9 months before the pandemic and 3 months after the pandemic. And I think it's really killing your associations there. But I think there could be a lot of signal in this data if you try to look it over with the methods that Kostas recommended, and maybe with adjustments, and maybe there's some hidden structure there. But I don't know if, as Kostas said, I don't know if we have any input from people who are more technically savvy, or even from themis, or people who are better than.
If I may, I like the presentation. It's really very nice. The results. I'm sorry, I don't have a camera. I cannot use it right now. Yes, I would agree that adding time points adds to the complexity of the overall analysis, and could be useful to apply some more sophisticated machine learning techniques instead of just statistical analysis. But this is something that we could help, and probably we could, as soon as we have some more data and more time points, we could discuss with Dr. Tsatali this issue.
Yes, of course. I would be really welcome to.
Adding time points to a problem changes the way. Changes the algorithms that could be used. For example, you could having 1 or 2 time points could be easier to use some more traditional machine learning approaches. However, if you go to 3 or 4 or 5 time points, then you could use sophisticated approaches like the dynamic Bayesian networks, or consider each patient a time series, and then perform a different analysis. Could be really nice.
Yes, unfortunately, I'm not familiar with machine learning, but I know it's the big deal to accomplish such complex statistical packets and data sets.
And Marianna, do the behavioral or depression instruments change over time? In relation to these time periods? Because I see you use them in fact in path
according
analysis.
To raw data. You are asking about their raw data?
I'm asking about if you use as an outcome the behavioral or the depression measures in the same way that you use the cognitive measures. Is there a difference in slope? Are there changes that relate to the pandemic period as compared to before the pandemic?
No, yes, the deterioration rate did not change for NPI, GDS, and SAST test. Okay, the raw data changed, but the deterioration rate did not change, and GDS was not able to predict the declination of the 3 tests, which were found to be worse after the pandemic. NPI was more predictable. NPI was not predictable for something that changed after the pandemic. But and SAST was was able to predict verbal fluency, and this is a common issue in our daycare centers, that those who have anxiety cannot perform well in verbal fluency. I know it from my personal experience, and I saw it also in the past. But yes, GDS was not able to predict anything, and no changes were observed by means of these 3 tests after the pandemic, according to the deterioration rates 1 and 2.
Could you just give us a high level, what was the MoCA change rate in the first period and in the second period, roughly?
Yes, MoCA, I don't know if you observed it, I passed the slide, was not administered in Alzheimer's disease dementia people because actually they couldn't perform this.
So what about just MCI? What was the MoCA delta?
MoCA did not change after the pandemic, so unfortunately I can't remember the...
So there was no deterioration on the MoCA?
No. The only deterioration for the tests administered in MCI was did it simple tests coming from the Wessler intelligent tests.
So somebody who had a MoCA of 22 had a MoCA of 22 for the entire period? You're saying there was no deterioration?
There was no deterioration rate. Of course, there was a deterioration. Okay.
So that's what I'm asking is, in the first period in MCI, what was the average MoCA change? Was it 2 points, 3 points? And then in the second period, I would presume it be about the same, but I'm just trying to get a sense of what was.
Yes, I know what you're asking about, but I don't remember for MoCA. Yes, almost all the tests were affected, but the deterioration rate was not different because we wanted to see what happens during the pandemic. Yeah, but yes, of course, all the tests were affected. The majority of them, not all, the majority of them were affected. Yes, it's a truth. We can say that we planted new neurons and something extroversive for a Nobel issue. The deterioration rate was something different, and the role of healthcare system to support people being isolated due to very serious circumstances such as the pandemic. This is a paper. Focuses on the role of dementia care systems, not about miracles coming from cognitive training. No, for any reason, for any case.
You do wonderful work. So it's the top of the hour. I want to thank you for sharing and doing such wonderful work. I'll throw out a question for the group in terms of thinking of future speakers, because I've seen this on a number of seminars. Would there be value to have 1 or 2 seminars on contemporary approaches to longitudinal data analysis? Because I think the level of sophistication, even without going to machine learning, has changed. And I think getting a better sense of things like mixture modeling, general estimation equations, might be valuable, because these are accessible tools now, and they're probably the right tools for this kind of analysis. So
yeah, it's a great idea, because you were thinking of inviting somebody who is more right.
Yeah, I was thinking one of my colleagues, Jeannie Lyketsos, who is really one of the major experts in applying these methodologies to longitudinal data in our field. So she's applied these both to longitudinal studies, but also to clinical trials where you have different kinds of questions and issues to deal with. She speaks in plain English, not in plain Greek. But I get your hesitation, because a lot of our high-level methodologists are not like Themis, who can sort of express themselves in human language, but Jeannie can do that. So let me.
I had a colleague, genetic epidemiologist, who was making shows, and she was asking, "Do you speak genetics?" if it's a different language sometimes.
It is. And I'd say 10 years ago, these analytic languages were not as widespread and understandable, but they are the state of the art right now. And so I think it's a good idea. At any rate, we've kept everyone long. Marianna, wonderful work. Thank you very much for presenting. And Thami, who is our next presenter in May? Do you remember offhand?
I think one of the group from Thessaloniki, from Kimiskidis group, I think.
Okay, wonderful. So we'll certainly let everyone know about that.
Mm-hmm.
Take care, everybody.
I think it's. Maybe we will have a presentation regarding some EEG data that Vasilis is trying to analyze from our group. So we're still working on that.
Great. Thank you all. Bye-bye.
Thank you very much. Thanks for your feedback.
Thank you. Bye-bye.
Γεια σας, καλή Ανάσταση.